the How I Do It session on asking the question, minimally invasive pancreatic duodenectomy ready for prime time. Now today we have some great supportive speakers that have expertise in this area. To my right I have Horacio Osban from Mayo Clinic, Florida, who has done both open, laparoscopic, and robotic pancreatic duodenectomy. And we have Mike Kendrick, who's the champion of the, with a lot of experience of the laparoscopic pancreatic duodenectomy. And then finally we have another successful John Cameron resident, Mark Talamini, who has a global overview of minimally invasive surgery that's going to put some logic and wisdom into answering this question. So I'm pleased to have you all here, and let's get started. So my short, brief introduction is going to be that the answer to this question is in the outcomes. The devil is in the details. The answer is in the outcomes. I have nothing to disclose. My question to you all is, why should we measure metrics such as outcomes that we're going to discuss? And there are four major reasons. One is to be responsible and accountable for what we do. The second is to focus on self-improvement. The third is probably most applicable to this meeting, is to assess developing technology. How is it really working, and then how can we improve it? And the fourth may be an antidote for others already measuring our outcomes, like Leapfrog, and then something like NISQIP, refuting that some skip measures may be unnecessary. Outcomes are very powerful objective tools for us as surgeons to defend and support and justify what we do. So let's talk about assessing developing technology. So the ideal method to measure metrics, particularly for the Whipple operation, is to have to select key specific outcomes that apply to a specific procedure, such as the Whipple operation. Then one is able to measure and compare those pre-selected outcomes. And finally, the hard part is to ensure homogeneity of our outcome measurements by having the same consensus definition of what we're measuring. This avoids misinterpretation and is assisted by a public web-based calculator for the outcomes so that everyone globally can use the same set of definitions. And at the end, the Pancreas Club has done this for us in regards to the public web-based calculator. So the common complications after a Whipple operation are its overall complication rate, which, as you know, is around 50%. It doesn't budge. But is that really the best way to define overall complications? There's probably a better evolving way. Second is excessive blood loss. Third is pancreatic anastomotic leak. And fourth is delayed gastric emptying. So those are the items that also compensate and are moved by length of stay and cost. So let's talk about these specific key outcomes. So we've got to have homogeneity to avoid this Tower of Babel in multiple definitions. And right now, how is the best way to measure overall complications? Well, I believe Steve Strasberg, through the various modifications of the Clavian classification that you all know, has helped us in the last 3 years with a number of publications to update. And he has provided us with the accordion severity grading system of surgical complications, where we don't want to know what the complication is. We want to know what its impact is on the hospital, the magnitude of the intervention required to treat that complication. So it's a UTI or it's a return to the operating room for bleeding. It's a different magnitude for those two. That's really what we want to know. And he has a very simple grading system for that. which is 1 through 6, and I'll go into this very briefly in the next slide. But if you think about it, this way we can compare Whipple's to esophagectomy. We can compare coronary artery bypass to total hip replacement and its impact on the hospital by knowing the profile of the incidence of these various complications from mild to death. Lowe and his colleagues published and presented at the SSAT plenary session comparing complications of esophagectomy and pancreatic duodenectomy, and indeed you can compare these very nicely. But basically when it comes to the Whipple operation, we took 500 Whipples and divided them into complications. One, as you see in the bottom, is whether they had to have new lines, catheters, or diuretics. And number 2 is whether they have antibiotics, TPN, or blood. Number 3 is whether they had to have invasive procedures without general anesthesia, like percutaneous drainage. Number 4 grade is invasive procedures that require general anesthesia. And then whether there was organ failure, and then whether there was post-op death as being number 6. And this is what the Whipple operations profile looked like. So there were very few 4, 5, and 6 complications, but the main way of estimating Whipple was this number 3 complications really is basically percutaneous drainage of fluid leaks. So if this profile is yours, then how does it compare to Mike Kendrick's and Horacio Asbun's? And that's what they're going to talk about in a minute. So this is the Achilles heel, and this is the grade 3s that are really the thing to make sure that you're within a acceptable range of complication magnitude. Now, excessive blood loss, Charlie Yo's paper is probably the one I use the most to refer to. If you lose too much blood, the survival goes down. So that's always a good thing to measure when you're developing new technology. It's a crude filter that is a way of getting started, but probably not as important as all these other items that we're going to mention. Then pancreatic anastomotic leak. It's too bad Claudio Bossi's not here because he started this in 2005. So the postoperative pancreatic fistula, we finally had a definition. I think Keith Lillimo mentioned right after it came out, says for the first time I've been able to discuss this problem with somebody else, and we were using the same language. And indeed, when this first came out, it was employed by everybody, and it was found that it was misinterpreted. It wasn't perfect. So a number of Tower of Babel definitions were being used differently. Therefore, Pancreas Club got with the experts. We decided what was the best definition, and we put it all down on a calculator that's web-based so that we can all do it the same way. Since 2005, there have been 50 publications of this ISGPS grading system for pancreatic leak. All of these had over 50 cases per report. And there were 16,000 cases that were evaluated. Yasushi Hashimoto prepared this for me as he helped a lot in developing this system with us. And the clinically relevant rate, what was it? So here are the papers. On the right side in the pink is what the clinically significant leak rate was, the BC rate as you know it. And here's the other papers. But basically, the BC rate for 16,000 cases was 13% using the ISGPS system. Now, delayed gastric emptying, the same group, the International Study Group for Pancreatic Surgery, through this publication, graded the severity of delayed gastric emptying, which is probably more related to fistula leak. But anyway, here is the way that it was done, and the Pancreas Club put this into the calculator as well. Basically what it is how long you leave the NG tube in, whether it had to be reinserted, whether a person's able to tolerate solid intake or not by whatever postoperative day. And it boils down to, if it's a grade A, that's most of our patients would be grade A because that's when we take the NG tube out, and they'd never have any problem after that. But it's the grade B, C's that are the ones that we need to measure. So those are like the clinical significant DGE rate. And when Keita Wada and Yasushi Hashimoto put this together for me on my cases, I was able to see that all I did to lower my DGE rate was to introduce microsurgery into my improved vision, and my DGE rate fell. So let's just talk about how one would go to calculate your own cases, and then I'm going to hand it off to Mike Kendrick. So if you go to the Pancreas Club website, at the upper top it says ISGPS calculator. Click on that, and it'll bring you this 14 question table. So yes, no to 14 questions, and push the button and it calculates what the severity grade is of the leak that you're entering. So the ISGPS leak will be calculated by these 14 questions, as well as the delayed gastric emptying grade will be calculated. Therefore, everybody uses the same definitions, and we're globally networked to the point where we're committed to improving using the same definitions. Now, the accordion scale, this just went on the Pancreas Club website yesterday, and if you answer these 8 questions, it'll grade the accordion scale, whether it's a mild, moderate, severe, or organ function failure-related complication. And it includes definitions for organ failure at the bottom that Steve Strasberg uses in his paper. So the perfect Whipple then has no blood loss, no leak, no delayed gastric emptying, right? Kind of hard to do, but a great series would have the following: a mean blood loss of less than 250 mils, a clinically significant leak rate of less than 10%, a clinically significant DGE rate of less than 10%, an accordion scale, Clavian scale, grade 3 of less than 10%, and the grade 4, 5, and 6, that is the general anesthesia, the organ failure, and death, of all combined less than 1%. I want to give a plug to Horazio's book. If you don't have this book and you're interested in the pancreas, you should get it from the ACS library. You know, 30 or 31 videos complete with chapters on, and the video explains each paragraph in the chapter on how 31 people do a Whipple operation.